I'd like to welcome all of you to Divine Mercy Care's first official live webinar. Our thanks to Zoom and to Mark for all the technical help. And here we are talking about why abortion isn't the answer to fetal abnormalities. It's divine timing to be here on the day of the Virginia March for Life. And we know late-term abortion is a big issue here in Virginia right now. And fetal abnormalities are often used to try to justify laws that would allow and sometimes even encourage abortion in these different difficult situations. So we're just honored, Dr. Bruchalski, that you would take time out of your busy schedule as a full-time doctor to be with us and help educate us on these things.
No, Cheney, it's good to be here. I've been on both sides of this issue. In my residency, the care was to provide abortion services for children who were sick. And so it's been a big change of heart for me. And so I'm very grateful that you're here. And I'm grateful to all you out there who are joining us tonight.
Thank you for being such a testimony to Divine Mercy. We really appreciate that. So our objectives tonight are really to understand fetal abnormalities as falling under three main categories: livable, treatable, and lovable. Now, abortion is never necessary in all of those cases. In fact, there are great responses to these categories. For livable conditions such as Down syndrome, we want to offer care. For treatable conditions, we want to offer treatment. And for lovable conditions, we want to offer perinatal hospice and explain a little more to you about that beautiful program that's offered here at Tepeyac OBGYN and at each of the certified pro-women's healthcare centers that Divine Mercy Care has certified through our new program, WHC.
And I just also want to add that this topic is very, very sensitive to so many of us. This is not easy to talk about or remember what's happened in our families. And so all of you out there who have gone through a termination for a child with a fatal anomaly, say, our hearts go out to you. This is a very common occurrence. It's also the only option so many of us ever gave before we really understood another way of approaching these cases, these people, these children, and these mothers. And so the first thing I just want to say is just a big hug over the internet here for all of us who have gone through this or who have known people who have gone through it. There's really should be no judgment here. This is just information for us to go beyond and heal from the difficulties that we faced in the past.
And we hope it's healing for you as well, Dr. Bruchalski.
Absolutely. Oh, absolutely. That's why I'm here.
All right, so let's just get started. We have some great slides here today. We're going to be talking about moral decisions, wrong decisions, morally neutral circumstances that families might find themselves in, and other circumstantial situations in which great moral judgment and prayerful discernment need to be used.
And so, and once again, before we get to the arrows, which you're going to see, which can maybe overwhelm you, there were just a few basic comments that I want to start now and then remind us again at the end. These are the takeaway points. One is that it's all about relationships between mom and her unborn child. Remember, these are conditions in which the child is welcomed, and some would even say wanted. And they find in the middle of the workup that there's a problem. So the first thing I want to talk about is a relationship. And you can tell the difference between the different forms of treatment by how the relationship between mom and child, mom and doctor are couched. I want to remind the medical professionals out there that we care for two patients always. We care for the mom and the baby. We never, we know that moms want to spend time with their sick children. They don't want to shorten that time. They want the disease to shorten if possible, but they cherish the time spent with the sick child, whether it's at the bedside, in the ICU, in the womb. And then as a principle here at Tepeyac and throughout all of our centers, we never pit mommy against the baby. Well, we have to make a choice here. You go and care for both well and do good histories and good physicals.
Their fates are intertwined.
Their fates are intertwined. And so those are the basic ideas that as you try to follow the arrows, don't get caught up in the colors, but just continue to listen to these principles resonate through the talk or through the conversation. Sure.
So when we talk about these three categories of livable, treatable, and fatal, or possibly fatal, but of course very lovable, we need to remember that very few people in our legislature, in our media, and even in the medical profession understand that these should be treated and responded to separately. Unfortunately, the common response in all three categories of abnormality is abortion. Abortion is what people rush to immediately. And in fact, I recently had a conversation in the airport with a medical student who had no idea that children with Down syndrome were being similarly lumped together with children with fatal abnormality, and that both of these moms would be referred to abortion. And Dr. B, can you tell us why that happens in the medical profession, that they immediately jump to that?
You know, I know that I jumped to that because of fear. Fear of bad outcomes, fear of suffering, fear of the unknown.
Wrongful birth lawsuits.
Wrongful birth lawsuits on one side, but also there is such a wide spectrum out there on these conditions. It comes down to just good medicine, diagnosis, history, physical taking, doing the tests we need to really identify how sick is the baby inside of you. We have to remember that the only way we can help encourage moms to end the life of their welcomed, wanted child is to distance them. So we begin to use words like fetus rather than baby. We talk about fatal, incompatible with life. We use language, and that language begins to build the wall between that relationship. And moms are moms. They're smart people.
Motherhood is a result of conception, not delivery.
Correct. And those hormones that rage and work through our bodies in that wonderful and mysterious way really sets that up.
That connection.
Yes, ma'am. And so as my cousin, my older Down syndrome cousin would tell me, am I a endangered species? It's because anything less than perfect becomes a tragedy.
But none of us are perfect.
None of us are perfect. And we don't allow my heart attack, my pancreatitis, my coma, my whatever I've had define me. And we don't allow
human dignity.
It's basically meeting the person where they are. And oftentimes it's these children that have been marginalized. They're the ones giving life back to us, not just the provider, the caregiver, but also the family, the brothers and sisters.
And the community.
And ultimately the community, because we're all connected. That's the issue. It's about relationships. It's about turning community into communion, because whatever happens to one of us affects all of us. Because who's to say that my bald head is a defect? But I don't want to downplay this, because Down syndrome and heart disease and brain trauma and these are real heartbreaking issues. But once you start the sliding slope, it's really hard to know when to draw the line, when something other than what is human becomes less dignified. And so as we go through this, it's real sensitive stuff. And so, yeah, let's keep going here.
So when we're talking about livable conditions, that's something like Down syndrome, an extra finger, or a disability that's not a death sentence. There is no need to abort these children. They have a condition, but like Dr. B was just saying, all of us have certain conditions that we have to manage and care for in the course of our lives. So care is really the response to that. And we're going to just dig into that more
Sure.
as we go along.
No, let's do it.
And treatable conditions like cleft lip and palate, that can be fixed surgically. There are amazing medical advances and more conditions like what the advancements we've made in spina bifida surgery that can happen even when the baby's still in the womb.
Once again, from a medical point of view, it all boils down to listening to your patient, reading the body language, the words that occur from the heart in between the words that come out of their mouth. And it's very, very important that we in the healthcare community, rather than quickly jump to terminating to get rid of the problem because it won't suffer, well, using language that distances you, we must do good history and physicals. And we must do good lab tests and ultrasounds and radiology tests.
No matter who your child
No matter who it is, whether it's the president with a chest pain on a trip, or whether it's your younger brother, or whether it's a child that has no skull, or a child with a genetic anomaly.
And that's why we believe in offering the same quality of women's health care to all women of means.
Right. And also
women that are in need.
And also to all children found in the wombs of their mother. Regardless, because I have to keep reminding, back when I was a resident, it's both and. You got to take care of both children. I mean, both patients, the mom and the unborn.
So let's dig in even more then. We've got better alternatives to abortion in each of these categories. Unfortunately, abortion is where people usually jump in all three of these situations, but sometimes they're not even letting enough time go by to go to the later prenatal appointments that you're discussing right now, and to see if perhaps at a later appointment the condition is recognized as gone or having been misdiagnosed, because as the baby develops more and as the technology develops more.
Oh, see, just once again, listen to what Shani said. It takes time to communicate with people, to allow that first, oh, by the way, you have cancer, your child is ill. I had cancer in my life, metastatic cancer. I don't think I listened to the next 15 minutes of talking after that. This is a legitimate, it takes some time, number one. Number two is you're spot on. It takes time for us to make the right diagnosis. How many times we think it's a right hypoplastic heart, but it's really a left hypoplastic? We treat those differently. But most importantly, technology that was, I'm 58 going on 59. The technology that was there when I was a resident, where all right hypoplastic heart babies, that's a baby that's right side of the heart is not developing, they were considered dead. They were considered not going to make it. They were going to, but as we've developed technology and we've had great collaboration across the world, there are now fetal surgeons at Children's Hospital of Philadelphia, Vanderbilt, Cincinnati, the Fetal Institute of Miami, where they're treating these already. So as technology grows, the age of viability, as we all know, when I was a resident, it was 25 weeks. Only 25, 30 years later, it's 22 and a half weeks.
And by jumping the gun, instead of giving that time, what we're doing is robbing the women of the relationship with their children, and we're robbing the chance that the child has to really actually be okay. And we're causing a lot of trauma for women. You were telling me that it's almost like PTSD if they jump straight to abortion because they were told so.
Oh, now once again, I'm prefacing this with my heart goes out to all of you who are listening who's had this happen, because I've done many of these back when I was a resident. I want you to know that I'm sure I've suffered PTSD. We had a young lady recently whose skull was missing and the brain was floating. And the first time I saw it, I remembered, oh my God, how am I going to abort this baby? Now that episode when I did do that was over 2 decades ago. And when I saw this new patient, it brought back all the feelings, all the anxiety. And I had to kind of readjust and just say, no, Johnny, these are 2 patients. Let's work through this. And that little girl, Mia, today is about 18 years old with a skull from Hopkins, going to school. Once again,
there are miracles.
There are miracles.
There are misdiagnoses.
But there are misdiagnoses, but it's there is much suffering here. When you hear that your child will not have the dreams you've projected onto it.
But every parent has to experience that.
No, they do, but for so many of us, it's brutal. We basically have to really catch ourselves, because it's in those moments that our hearts become hardened if we allow it. And so I'm just grateful that time has shown better diagnosis, better technology, more accurate technology, treatments we can do in utero, but also because we're caring for children smaller and smaller, the age of viability is lowered. And we give these children what used to be a death sentence
is now
30 years ago is now
bump into the
right.
treatable category.
And the question becomes, is 3 years of life, how many of us wouldn't want to spend time? What happens if you had 1 month or 1 minute more with your child? I've heard this now from so many of my patients, and I've also learned this. I'm sitting here tonight with you all, but there are some wonderful doctors that I happen to work with closely. Dr. Marie Anderson, Dr. Dan Fisk, Dr. Miriam Pereira, Dr. Lorna Svetkevich, Kim Terhune, our midwife. I'm speaking because I know them well. This is something that we all deal with. We want to make good diagnoses. The PWHC centers that we have partnered with or have this consortium that we have certified under standards, these are folks that will go the extra mile to do excellent medicine, both before, during, and after the delivery of your child.
And allow the family to decide, you know what, we're not going to do
Correct.
the genetic testing, or allow the family, okay, if you're going to genetically test, we're going to walk through you if the results aren't what you expected. And there's a beautiful attitude to that that's so different than the abortion industry and mainstream medicine.
And once again, all of us, many of us have suffered children that our favorite doctor said, no, we really need to deliver early and just get beyond it. And once again, we don't,
that child at risk.
We do, but we don't, once again, that challenge between what actually happened and what's going on inside our hearts.
There's so
much
mercy.
This idea of relationship, most of these children that we deliver that are very sick, Cheney, they are remembered in their family. It's not considered a child that didn't make it. It's actually my brother Jimmy, who had no kidneys and couldn't pee, so he didn't live very long. And once again, doesn't make it easier, because what we're talking about here is the relationships that come about through suffering.
Absolutely.
And it's worth it. And yet we can't judge, but we offer this as a real opportunity to spend more time with our kids, especially the sick ones.
So just getting back to the chart here, you'll see that if the child makes it to birth, there's that chance even at birth that it could be recognized that the child just doesn't have a problem anymore. Maybe never did if it was misdiagnosed.
There's enough stories out there to agree with that.
So many stories. So what we're really trying to do is give these children the best chance they have and continue to reinforce that maternal child relationship that we're really emphasizing.
And we don't want to, how do I say this? We definitely don't want to give false hope, but hope is something that we're always giving to the mom and the child in that relationship to that family. Because it's not always about getting rid of pain. Hope kind of helps us work through the pain, not bury the pain or forget the pain. So yeah, let's go ahead.
So in livable situations, Down syndrome most commonly, after the birth of the child, there's there's really three different paths. You can parent the child. You can place the child for adoption, which, like any adoption, can be a moral decision if done in the correct circumstances where the family can't care for the child. Or unfortunately, the baby can be killed, and the baby might be killed directly murdered, or there might be an infanticide situation where the child's left to die, in this case, left to die from starvation because their condition wouldn't have killed them. This was done in ancient Rome all the time with defective children, and we think it can't be done in America, but in the cultural shift that we're seeing, we're not so sure anymore. And I know you said, Dr. B, that there were some situations that you've seen even where children were neglected, abandoned, and died.
Yeah, let's on the side here. Once again, it's Down syndrome. It's a very common issue. Many of us know people who have Down syndrome,
and are a light to their families' lives.
And they're living longer, and they're living, once again. Children with Down syndrome are just like me, a child with asthma. You can have all different spectrums, all different severities. And so what happens is that as you come to know your child and come to know the illness, back in the 50s and 60s and 70s and 80s, we were able to identify these children at birth and then care for them oftentimes.
And we need to care for them today.
And it was through the wonderful work of Dr. Jerome Lejeune and the Lejeune Foundation in Paris, and now coming here. Tremendous work, because he wanted to help study and care for these people to figure out what was wrong so he could treat them. And once again, thinking that you can treat a child with Down syndrome, that's the kind of hope and the dedication to excellent medicine we need. So we need, Dr. Lejeune has passed away now, and so we need to just really remember what he was trying to do. And so a lot of times, these early genetic testing that we're all told to do very early on, it's just so we can do the abortion earlier. Now, many good moms will say, well, I just want to prepare myself to handle the challenge. It's very hard to, because the spectrum is so varied. Some children have severe heart defects along with Downs. Once again, Downs doesn't define them. It's part of who they are. And when you're looking at the kidneys or the brain or the stomach or the heart or the liver, it's part of who they are as a person, right? And so, yes, we hear all the stories of how a Down syndrome lights up the life, the generosity, the joy that the child radiates, the young person radiates. But sadly today, most genetic counselors have gone from 5 to 10% thinking that it's okay to terminate and abort that pregnancy. 90% of children today, maybe 95%, that are identified with Down syndrome in the womb of their mom are now terminated, aborted. It's just kind of the standard of care. And it's so heartbreaking.
But it's not our standard of care.
It's not.
And when we say parenthood here, we don't mean that these families are left in these difficult circumstances, suffering alone. We're walking alongside them. We want to care for them. We want to walk alongside them in the womb, and then more people come along and walk alongside them through parenthood. So we really just want to emphasize hope here, and love and community over and above the option of abortion for livable conditions.
No, without a doubt. And, hooking families up who have gone through this and who have suffered the challenges, but also have experienced the joys, and then getting that perspective from a distance when you've been with this child for a while.
The mentoring that can happen.
Right. And this, once again, in certain cases, it is challenging. And yet so many of these families, they wouldn't trade it for anything in the world. And it's that type of, when I would, back in the day, I aborted a young couple. She was 27, he was 28, the mom and dad. And we did a genetic test on them, and her risk went from 1 in 10,000 to 1 in 1,000. And the test came back positive. So her boyfriend back in the residency said, "Oh, hey, John, Dr. John, that's great. We can handle 1 in 1,000. And the young lady looked at me and said, no, we can't. I'm afraid. I really think there's something wrong here, and I'll never be okay with it. So being the doc at the time, just giving them what they wanted, I terminated that pregnancy. I aborted that pregnancy. The child was healthy. Once again, fear, anxiety is always with us. It's part of human nature. And it's trying to meet people where they are and accompany them with real compassion. Not just empathy, not just sympathy, but real compassion, trying to walk with them. And that's ultimately what good care is: finding resources, finding support groups, working, giving money to, whether it's, the Jerome Lejeune Foundation. This is really what it's about, walking with. And so I think that gives a good idea of what I've seen.
And so now moving on to the treatable conditions, after the birth of the child, really the best option again is treat and parent with the support that they may need to have access to the medical care that the child needs. When that medical care might not be available in other countries, we might have to provide a version of perinatal hospice for those children. But for the most part in our nation, we're able, as you said, to continuously find better and better medical treatments and to give these children a wonderful treatment.
In this category would be, say, cleft lip and palate. We know that in certain parts of the world, it's considered an abomination to be born with that. You sinned, your family sinned, something's wrong, the devil got into you. And so I was down in Norfolk where I trained, in a great city with a lot of good medicine. And there were a bunch of plastic surgeons who said, no, we're gonna make Operation Smile. You've all heard about it. It's been on TV. They go all over the world.
One of my very first charities I ever donated to as a little girl.
Operation Smile is a bunch of docs who go to these third world countries and they just set up cleft lip and palate. Cleft lip. Now that's a surgical fix. But once again, we're taking care of 2 patients. I'm trying to diagnose mom's issues, but also we're using ultrasound and MRIs to look at the baby in the uterus. That means through the skin, through that extra weight put on, through the muscle, through the tissue, through the fluid. Well, it's a challenge to make those diagnoses, whether it's hypoplastic one heart side. Remember, hypoplastic left heart is fixable. Hypoplastic right heart many years ago was not. And you really have to wait till after birth to do the appropriate echocardiogram or the ultrasound of the heart and do it right on the chest of the child to make a better diagnosis, because we must always do good. We must listen. We must listen to the patients as well as listen to the data that we're gathering.
Because excellent medicine is a very important part of what you feel called to do.
Excellent medicine is about treating the underlying problem. It's like making a diagnosis and then treating the diagnosis.
That's what medicine should be, not distraction.
Right. And it's hard because so many times in these third world countries, it's just easier to get rid of these children because of the suffering. Wait a second. How pathetic have we become that we're going to get rid of cleft lip and palate by getting rid of the child with the cleft lip and palate? Wait a second. You don't get rid of a disease by getting rid of a child with that disease. It doesn't quite work that way.
No.
And yet we're also now on the verge, which is another talk, genetic engineering, where we're using CRISPR to manipulate genes to try to prevent this. We're living in a brave new world, and so many of these conditions, and I've done them, where an extra finger, the child was terminated. Or right now, one of the more common things that maybe we all have had with our children is that little white spot inside the heart. It's called an echogenic focus. If the baby looks healthy otherwise, all that is a little reflection of a papillary muscle inside the heart, which is normal because we're catching it end on rather than lengthwise. There's more density. But if we find other problems, midline defects, breathing problems, lung problems, heart, it might be a sign of a genetic anomaly, trisomy 13, 18, 21. Well, everybody sees it and jumps, go to Google,
To conclusion.
they jump to conclusions. Is my baby okay?
It's a fear culture.
Right. And fear is not just of the Lord, but in healthcare, illness, death is all about fear. And it's very easy to slip into that mindset that I'm afraid to parent, I'm afraid to go forward, I'm afraid to get sued. And I just want to, thank all our patients who have been so kind in these difficult cases, and how they have shown me what real love is. Sacrificial love that goes through the fear and understands that, many of us have made these tough choices based on pure fear.
And sometimes you were even telling me that instead of an abortion prior to birth, you might use inducing birth too early as a form of abortion, essentially, that is putting these children at risk when they may have had a treatable condition. And that risk was too much, that fear took over. And in some cases, you have just said, let's just deliver the baby now, even though there wasn't a real medically necessary reason for that intervention.
It occurs in many different ways, Cheney, and our audience. Babies with large heads, hydrocephalus, that used to be called water on the brain.
Right.
A lot of times we would deliver them very early because we didn't think that they could, that they couldn't think, or that their brains were so damaged. And yet, in some of those cases, those brains will almost reinflate when you drain the fluid.
Right.
There's treatments for different types of hydrocephalus. Number two is, I still remember the case where a woman's water broke just a little bit. She was near viability back then, which was 24, 25 weeks.
Right.
She didn't want the child. I didn't do a very good history, and I induced labor.
For no medically necessary
Well, I was
reason.
afraid that the baby might get infected.
But there was no evidence.
But there was no evidence of it, and the mom didn't want the child. So I delivered the baby, and I had to call the neonatologist when the baby was born because it was over 500 grams, which means we had to resuscitate the child. Very awkward. But the problem was on me. I was the one that didn't do the good history and physical. I was the one that basically said, the child's not worth anything because the mother doesn't want it. I wasn't thinking, I didn't take a good history. And so this is a real issue, and we've all kind of gone through this. So
thank you for sharing out of your vulnerability.
Oh, please. Yeah, no, we can go on, sure.
So moving to the third category here of fatal or possibly fatal conditions, such as anencephaly when a child's born without a full brain, or trisomy 18, which is not always fatal, but certainly can be in certain situations. And so after the birth of that child that has that diagnosis, if it's actually treatable after all, it would move to the treatable category that we just discussed. But in certain cases, there may be some kind of treatment available, but there might be unintended consequences. And so, Dr. B, I'm hoping that you can dig in for us this conundrum of these children that are very sick. What kind of medical intervention is appropriate? How do you make that call for these babies of, is it when would you resuscitate the child? When would you engage in a treatment that might be so aggressive that it might lead to system failure anyway?
Right. So I'm not the pediatricians, but we're the ones that set up that child for the best care afterwards. And so what we're talking about here is not so much the trisomies, because they are in and of themselves a little different case, but these are the cases where the doctor says there are so many anomalies, there are so many problems with so many systems, the brain is totally malformed. The mouth doesn't connect to the stomach. There are very few kidneys. The intestines are all jumbled, and the baby doesn't have a bladder. That child is not going to make it. And so we use the word of a non-viable diagnosis. It's non-viable. it's non-viable. Not your child is really sick.
Now,
And that's the whole idea of behind perinatal hospice. When we do the best medicine to try to care for the child in utero, and we find real problems, real sick, severe outcomes with multiple system failures, we use the womb as a hospice. For any of you medical folks in the audience, Byron Calhoun's article, he talks about, as a high-risk OBGYN neonatologist, he talks about perinatal hospice, how we use the womb as a hospice, how we care for that child for as long as the child's with us, because we know that once we deliver the child, it's not going to live very long.
so
This
when
is
the
not.
child is born,
Yes.
like, for example, the child of our board chairman, Kathy Doherty, she's been very public with her story of her child that was delivered, and she was told that her child had a fatal condition and would not live past birth. She was pressured to abort. She didn't. She found the Kristen Anderson Perinatal Hospice Program at Tepeyac. And then when her child was born, they made a determination that there was something they could do. There was a treatment available. And in fact, her child is 6 years old now. And they've had challenges and they've needed surgeries for little Maggie, but they walked through that as a family, and they say she wouldn't have been here if they had listened to those initial doctors. And those kinds of miracle stories are what people can miss out on.
You know, it's the same issue that we see with, say, like the Santorums, who've been very public with their trisomy 18 daughter, Bella. How they've cared for her and they've kind of just gone the extra mile, but you know, she's with us and she's Bella. I mean, she's her. And so I just want folks to know that there are conditions that are just as serious outside the womb. And for those precious moments when the family is, once again, when this child is so sick that there's multiple system failures, do we really want to send this child to the ICU
for the little time
that they have? We want to maximize the time with the child. So that's why all of these services that I know we've partnered with, whether it's Laura Ricketts or Paula Stryker or Be Not Afraid, there's many good groups out there that really want to help you as a family walk through this, because it's not easy to say goodbye, to know that when you clamp the cord, this is going to be the few minutes you have, whether it's minutes, seconds, hours, days. So there's one case here where these children are severely sick. The blessing is that we get to maximize the time with the family, that these children are celebrated. They're not kind of pushed aside as monsters. And that's part of it, because remember, up to that point, many doctors are trying to put that language divide between mom and child. It's going to suffer terribly. It looks like a monster, or it looks very deformed. And the moms and dads have to do these things in order to deliver early, knowing that they're going to shorten the time with their sick child. It's really tough on all of us.
I just want to emphasize that hearing some of our patients tell their stories can be a powerful part of understanding the full picture behind perinatal hospice. Recently, Kathy Doherty, our board chair, joined Mary Sue Hempler, one of our infant loss program volunteers, to be on a podcast. It's posted on the media page of our website. I encourage everyone to go to divinemercycare.org and find that, because the two of them tell their stories, and Kathy explains how her child survived, and Mary Sue explains how her child died. But they both were treated with love and care every step of the way, as mother and as child. And even though the outcomes were different, the attitude of their heart was the same.
So, and I just, once again on this, Dr. Marie Anderson, whose daughter is the name of our particular perinatal hospice, the Kristen Anderson Perinatal Hospice. I have learned so much from Dr. Anderson, who has walked with so many of these patients to whatever outcome, living, dying, treating. She has been a real role model, and we can help one another do this, because this is, when we give women the option of perinatal hospice, we believe that over 80% choose it.
Yes.
And yet, it's very rarely ever given as a real viable option. And it's not something that most doctors have to really learn. It's just delivering the baby, as keeping the baby inside mama as long as possible, doing the best you can for mom and child. And then when you really assess that the child is beyond simple care, beyond reasonable medical care, you allow the child to spend the maximum amount of time.
But they're not dying in a neglected state where their value is up to discussion, or where they're tossed aside or put in a bucket, or any of that. There's a huge difference between that attitude and the attitude of giving the child to the mother, letting it be held, loved, passed around for the family. It's not.
Once again, in a very graphic way, this is the difference between the Gosnell Clinic, that house of horrors in Philly, and the Children's Hospital of Philadelphia. It's about relationship. It's about great medicine. It's about doing the things you can do. It's about not doing the things you shouldn't be doing, on both sides. Giving too much care to a baby that is already failing. We want to bring in the priests and the pastors and the faithful friends. We want to introduce that child. It's not like a dirty secret that we're going to put in a bucket and try to kill it before it comes out.
And this discernment is similar to an old person in hospice, where you don't always do medical intervention after medical intervention trying to reach immortality. When you recognize mortality is present, whether the person is an elderly person in hospice or a little baby in perinatal hospice, you give them the same dignity, the same discernment as to what medical interventions are appropriate, and the same love and care.
And I think this is just something that's going to be on the horizon. More and more people are asking for this, because they're realizing that some of these cases are not as simple as we make them out to be. And, but I learn a lot. We all learn a lot by walking with patients who have this, and grieve with them when they grieve, and laugh with them when they laugh.
So one common objection to going through with perinatal hospice is often, my baby will feel too much pain. It'll feel too much pain with its condition in the womb, and it'll feel too much pain when it's born and dying. So could you speak to that?
Just for a few minutes, and just to make it very basic for all of us. There are sensory endings on the skin of the child as early as 8 weeks, including around the baby's mouth. Those sensory networks are beginning to grow nerves both from the spinal cord to the fingers or mouth or face, as well as sensory fibers from the spinal cord to the brain.
Amazing.
We know that somewhere between 14 and 20 weeks, it's connecting to the thalamus, which is right in the middle, which is kind of like a junction where the higher centers, well, most of my friends and associates who are abortionists, they basically say the child feels no pain because it's really not until 26 or 30 weeks. Then why do all the fetal surgery centers in the nation use anesthesia and analgesia with all the fetuses they operate on between 14 and 30 weeks? Once again, when you're going in to try to help a child, even now, man, I'm old enough where I remember my first few circumcisions I did as an OB. We used no anesthesia. The screaming, the tearing of skin, I truly did not do, I didn't want to do circumcisions. But now we use anesthesia. We know it's not for salvation anymore, but cleanliness, for family issues, for culture, we're good, because we now treat the baby with an anesthetic.
So
now,
when a child is going to be aborted, what you're saying is that they're going to feel pain. It's very likely that the way to have your child avoid pain is not actually abortion.
It's the reason why most second and third trimester usually get digoxin or potassium to stop the heart before it gets delivered. That's why we have the Pain Capable Act, because so many of these abortions are born and the baby is just covered up with a blanket. Because remember, it's supposed to not make it.
But what if the child has one of these fatal conditions and the mom has said, all right, I understand now, abortion's going to cause pain for my child. I don't want to risk that. But this condition, as the child is dying, is there anything I can do to help
Right.
help my baby not experience pain at that point?
Once again, many good pediatricians who are with you at that time really provide good care for the child, pain-wise. I don't know if I share this, but I've been in a coma before, a uremic coma. My kidneys were dead. And I had severe pancreatitis. And I don't remember, I had severe pain when the pancreatitis was present, but I wasn't connected to my mother getting all the nutrients. When I slipped into renal failure, I felt nothing. I didn't remember it. It's a slow, you kind of fall asleep. And so many of the children we care for them just like we would care for any hospice child. If they're struggling to breathe, we comfort them. Because by the time they're there, they're already so far down the line.
And that relationship can actually help alleviate pain and regulate breathing as the child's dying.
Correct, because you've bonded with your child. I can tell you that there are many good studies out there that really show that the child will react in a what appears to be painful way, even when there's no cortex attached to the thalamus yet.
Wow.
So even babies with no brains have a thalamus much of the time, and they reflexively pull back from pain. In the old days, we had to break these children up, kill them by D&Es. But now it's mostly just delivering them early, giving them medicine to push them out of the uterus. We don't monitor them. We treat them, we just treat them more like tumors rather than your child. And I know that's how I described it when I was doing that. There are many good docs out there who still believe in this, who try to do what's best for mom. We don't judge them.
So if the child's delivered alive after a failed abortion, which is the conversation we've been having a lot of time politically, a lot of times those children, if, for example, the heart wasn't stopped before delivery or something, and because it's hard to aim, and the child actually born alive. Now, if they don't have a fatal condition, then of course resuscitation is immediately called for, and all the medical care they would need. It's unfortunate that an abortion was even ever attempted. And in the case of a fetal condition, they certainly shouldn't be neglected or left to die in a bucket. They should be loved and cared for. And unfortunately, I don't think our governor or legislators understand perinatal hospice as the proper medical intervention in the case of a fatal abnormality.
I think so many folks, it's just known. Why would you do that? Suffering doesn't have, it's not part of a family.
But the irony is the suffering comes even more when women realize what they've done.
Whether it's Bernard Nathanson or whether it's Abby Johnson, once you see, or John Bruchalski, what you see on ultrasounds, it's definitely a challenge in there. But I don't know how late we're getting here, but if there's any questions out there in the room who want to get involved here, please send it over the Zoom group, right?
Yes, please use the chat box. And as you're chatting in your questions, I want to ask Dr. B just to share one very meaningful story from the provider perspective of what this kind of perinatal hospice can do to the hearts of doctors that were previously recommending abortion in these cases.
A wonderful gentleman was taking care of my patients when I was sick, when I was on chemotherapy. And he happened to deliver one of our special children, one of the children in our perinatal hospice before we called it a perinatal hospice, a young family, Hispanic family that had an anencephalic baby. And that means a baby without a skull, without a brain above the thalamus. And they delivered near term vaginally. And he was on call the night that he picked that up. And late that night, he came storming into my office, storming into my hospital room.
You were
I was getting chemotherapy. And he says, "I'll never do this again for you. I just delivered a monster." And it was like a joke. "What are you doing? Why didn't you get rid of this before time?" And I said, "Sir, I'm so sorry. I forgot to tell you. I was already, bloated and swollen from my chemo." And he left in a huff. This was about 11:30 at night in the hospital, and I felt terrible because he was a good
He
man.
was trying to cover for you.
This is a guy that I respected.
And you wanted to warn him, but didn't get a chance.
Didn't get a chance to. So about 7 or 8 years later, he came back into my office with a picture. He knocked on the door and my office here, and he walks in and he sits down and he says, hey, do you remember that case? Oh yeah, I remember that case. He says, I want you to know that I was angry because I tried my best for my 30 years of care to achieve that type of love in that room.
Mm.
And then he says, with all due respect, there was more love in that room with the extended family, celebrating the life of a child who had no brain. They passed the child around. They introduced this child. They named it. They passed it around to all the sibs, all the family members. They sang songs and loved this child until it died a few minutes later. He said there was more love in that room than in any room I've been in, and I don't see this. I can't do this anymore, Dr. B. I don't think I can end. I want to work with this hospice concept. That's what we talk about transforming hearts through healthcare. It's what we do.
Abortions anymore.
No. And it's a real challenge because only by engaging people in their darkest suffering that we really find how human we are and how lovable and how loving we can be.
Mm.
And it's that battle between our dark angels and our bright angels. And so, you know, this transformation affected me deeply because I know I experienced it, but then I saw a dear friend of mine experience it. And so I just want you to know, thank you so much for joining us.
I'm going to unmute everyone right now. If you want to stay on and ask us any questions, we're here for the next couple of minutes. And so here everyone is on unmute, but please mute yourself if you don't intend to speak quickly here so we don't have too much feedback. And are there any questions?
It's very common not to have any questions after a topic like this.
It's very intense.
But we just want to thank you. Because in a world where so many people want abortion on demand for any reason at any time, up until birth and even after birth, perinatal hospice is a great solution, as well as being a good doctor and healthcare provider, as well as a midwife and a nurse practitioner. And we're just grateful for so many of the folks that have come and came to the practice. And we've been able to walk with many of them. Most of what I spoke about tonight, whether it was about relationships building, not separating or shortening, whether it's about caring for two patients, mom and baby, past the nausea, past the hyperemesis, past the morning sickness, through the diagnosis, whether it's genetic or structural or physical or emotional, whether it's with the mom who gets sick. We care for two patients. Moms want to spend time with their sick children. That's a real principle that I think is hardwired,
especially when
into
they're sick.
Into that small, quiet voice that we call conscience. We also try never to pit mom against the baby. And when we do make mistakes, you call us on it, and we're grateful. And so, once again, using the language, this is not a child with a disability. This is not a special needs child. This is a child, this is your daughter or son who happens to have a list of issues that need to be treated. And I believe someday that there will be centers all across the world where Down syndrome children and children with trisomies, we will have studied them and cared for them well, to the best of our ability, when they're 1 minute old in the uterus or 2 years old or 10 years old. Because as we know, when you have great health care, people live longer, they live better, they live cleaner, they
health
eat.
Is based on relationships.
Health is right, and it's about eating better and giving the right nutrition. We're now working with nutritionists, and we're working with perinatal hospice grief counselors, women who've gone through this, who will walk with you, photographers to commemorate the event rather than bury it in the back of your mind.
So I just want to point everyone to our website, divinemercycare.org. We have an infant loss page on there that has perinatal hospice information, resources. We're continuously updating them and making them better. We need more volunteers and donors to continue to increase our infant loss support programs reach. And we hope you share this webinar recording with your friends. We'll release it after this. And if there's any person who's come across this webinar and who's watching this, who's really trying to discern what to do in the case of an adverse diagnosis, maybe you feel pressured into an abortion, maybe you know you don't want that, but you feel like you have no support, we just really want to encourage you to contact us at divinemercycare.org. We're here for you, and we want to advance pro-life healthcare and all that means. And really, mother and child together is what that means. Life, we want to love you.
Life affirming, and even for all of us out there who still regret what happened in the past, it is good to still talk to folks, especially some of us who've been on both sides, knowing that there were many circumstances and many issues at the time. And we do suffer, and we do need forgiveness, and it needs to be a two-way street. And there are ways to work through that. And we want to give you a toolbox, because it's not just a technical healing. It's a body, soul, and spirit. It's integrated. It's both and, again, as I'm too often fond of saying. It's about not just reading something and then adapting it. It's letting it filter through, you know, the eyes of our heart and the ears of our soul to a place where we can really celebrate that child's life rather than remember the darkness or the sadness, that forgiveness that only comes through relationships with ourselves, with our Creator, with our Father in heaven. And so thank you so much for joining us.
We'd love to have a relationship with you. Email us at info@divinemercycare.org. Log on to divinemercycare.org, and we hope to see you soon. Let us know if you like this webinar and want to see more.